Hello to everyone watching this video. This is Seo Kim, and I would like to thank the editorial board members of KJR for giving me such an honorable opportunity to present this research on behalf of all the authors, to the readers of KJR and subscribers of this YouTube channel. The title of our research is Diagnostic Performance of Spin Echo EPI MR Elastography in 3 Tesla System for Non-Invasive Assessment of Hepatic Fibrosis. These are the table of contents, and I would like to begin with the background. Well, as many people know, hepatic fibrosis and cirrhosis is the common final pathway of various chronic liver diseases, and accurate staging of liver fibrosis is of profound importance for prognosis prediction and optimal treatment planning. Up until now, the gold standard method for diagnosing and staging hepatic fibrosis is percutaneous core needle biopsy, though with the clear disadvantages including its invasiveness and its inherent vulnerability to sampling error. And among the non-invasive alternatives of percutaneous biopsy, MRE possesses strengths over other methods owing to the larger sample volume and higher technical success rate and less operator dependency. Especially 3D spin echo EPI MRE is accumulating more and more evidences to show equal or even better performances compared to conventional 2D GRE-based MRE, mainly because of its less susceptibility artifacts in higher field strength MR systems and better spatial resolution along Z-axis. However, since the technique is newer, the published evidences of this method is fewer than those of GRE. So the purpose of our study was to validate the performance of 3 Tesla spin echo EPI MRE in staging hepatic fibrosis in a large population using surgical specimens as the reference standard. For the study population, we included 202 patients who have undergone hepatic resection from 2014 to 2019 in our institution with preoperative 3 Tesla spin echo EPI MRE within 3 months before surgery. And we added 157 donors who have undergone donor hepatectomy from 2017 to 2019 with the same MRE, and excluded 38 subjects according to the following criteria, and finally included 321 subjects. And the MRE acquisition was done according to the following protocols. And MRE was interpreted by one radiologist with 5 years of experience in abdominal radiology. This is an example axial anatomical image showing portal vein, hepatic vein, IVC, and a tumor. And after we get the grayscale MRE stiffness map, a confidence mask with a 95% threshold is automatically provided by the software. And on that map, the radiologist drew freehand ROI only on valid areas of a confidence mask so as to include the largest part of the liver parenchyma on the right lobe and left medial segment, while excluding the large vessels, liver edges, and focal lesions. The mean LS values, liver stiffness values of each ROI were recorded, and the arithmetic means from 4 slices was determined as the representative LS of a subject. And among these images, 20% of cases which were randomly picked were sent to the second radiologist to be interpreted with the same method for evaluation of inter-observer agreement. 11 subjects were further excluded because of the technical failure, which means technical failure rate was 3.4%, and inter-reader agreement was excellent with ICC of 0.98, and only a few outliers showed profound differences in measured liver stiffness values. In the patient group, the hepatitis B virus was the most prevalent etiology of CLD, followed by alcoholic liver disease and hep C virus. And 86.5% of patients had significant hepatic fibrosis, while 96.8% of donors had no or mild fibrosis. The mean LS values were calculated in each fibrosis stage and were compared among different etiologic subgroups by Kruskal-Wallis test. And in cirrhosis patients, those with alcoholic liver disease or PBC showed significantly higher stiffness than chronic hepatitis B patients, and PBC patients had significantly stiffer liver compared to those with chronic hepatitis C. Overall, the stiffness of F4 group in non-B patients were higher than in CHB patients. And ROC curve analysis for diagnosing fibrosis of F2 or more, F3 or more, and F4 stage were done. And AUROC's cutoff values, sensitivity, specificity, and Obuchowski measure were calculated. AUCs and sensitivities and specificities were very high, as you can see in this table, and Obuchowski measure was also good. And the same cutoff values from the total subject analysis were applied for CHB subgroups, and the result showed a slightly decreased sensitivities and specificities, but the results were still comparable. And the subjects were divided into two groups for internal validation. The cutoffs from one of the two groups was applied for the other group for validation purpose, and the result sensitivities and specificities were satisfactory, as you can see in the table. So in conclusion, 3 Tesla spin echo EPI MRE demonstrated high technical success rate and inter-observer reproducibility, and the liver stiffness values in patients with non-viral cirrhosis were substantially higher than those in patients with viral cirrhosis. And our cutoff values for staging hepatic fibrosis showed quite satisfactory diagnostic performance. Thank you very much for your attention, and please refer to the published paper on KJR website for further details of our study. Thank you.